Welcome back to the program, 423. And from time to time, we get together with Paul Seegert, managing partner at PCF Advisors here on the Randy Tobler Show. And Paul has his finger on the pulse of government policy, how it affects you, your healthcare expenses. And we want to talk about how the Schumer Manchin bill may affect your expenses. And some of you out there might have some effect from it. Paul, thanks for joining me this afternoon.
Glad to be here. How are you today?
I'm good. You know, we were talking earlier that I was telling the audience, it's like, you know, even though philosophically us conservatives know that there's no such thing as a free lunch in the big picture, but some people benefit from some of the tax and spend policies of the Democrats. Let's call it what it is. And in this case, a couple of the provisions that Manchin and others are celebrating and parading around is that it's going to lower drug costs for seniors. I think that the insulin, the $30 insulin cap may have made it through there too. But let's talk further. There's also some health insurance provisions. What is, for some folks out there, maybe if this bill does pass, if Sinema does vote yay, and I don't think she's claimed yet whether she will or not, what are some of the potential benefits that people might have out of it for drugs?
Well, yeah, I think the biggest thing we're keeping an eye on is the fact that Medicare may essentially put in some price controls on 10 or 20 of the top drugs that Medicare spends money on. And we can talk about the good and the bad of that, I think, in the long term, because there's definitely some unintended consequences that look like they're shaping up from it. But the idea is that those with Medicare would be able to access those drugs more affordably, Medicare itself at the payer level, at the plan level, but then that could trickle down to the members in Medicare, specifically for some really high dollar drugs for things like cancer treatment and so on, which oftentimes, I mean, you know, bankruptcy is still medical bills are still the number one cause of bankruptcy, even for people with health insurance in this country. So hopefully that will play out in such a way that it benefits those average Americans, where they're not rapidly hitting their max out of pocket.
I read that the max out-of-pocket drug costs under this bill would be $2,000 a year for Medicare beneficiaries. How does that differentially affect people that do the Medicare Advantage plans versus straight Medicare with and without Part D Medicare? We have to get a little bit into the weeds here, but Part D is optional, if I'm not mistaken.
Right. Yeah, and I think really what they're saying there is that your Part D out-of-pocket won't exceed $2,000.
Ah, okay.
So there'll still be a need for Part D, but you'll know, okay, because there's been this problem really forever of what everyone calls the donut hole with Medicare, where you can have this runaway drug expense, even though you buy all the parts, and hopefully this will kind of shore that up.
And then you said something very critical that slipped by some ears probably, and that is that Medicare for the first time is going to be able to negotiate. We'll have to talk about how that one-sided negotiation works. I love the way they do that. They're going to strong-arm pharmaceutical companies, but only on a limited number of drugs. So it's not all drugs, right?
That's true. So let's say they start with 10. I think which is probably part of the reason they're starting small, is that it would be easier to get it done and face less opposition. I've read certain analyses about it where they say, okay, maybe this would impact 2 or 3% of big pharma's total revenue. That doesn't mean it's not a concern, though, for the pharmaceutical industry because of the precedent that it could set. And really, if you were to ask the listeners, does it sound like negotiation if someone that wants to buy your product says, and let's say you want to charge $10,000 for your product, they say, well, we'll give you $2,000, and if you don't accept that, we're going to hit you with a 95% tax or fine or penalty on the revenue of your product. That's not really an even negotiation.
That's right.
That's scary, really.
Right. Yeah. They're strong arming him. It's basically price control. And well, as long as we're at it, how's that going to affect I guess the other thing is vaccines would be covered. And as far as I can tell, it's all vaccines I think might be covered for seniors. What about what are the long-term ramifications? I mean, last time I checked, pharma's not hurting. Their bottom line is a lot better than most doctors' offices and hospitals these days.
That's right. They're doing great. They're doing great. I think the issue I see is that most of the times when people say, hey, we can't lower the cost of drugs because it'll hurt R&D, it's usually a red herring. I mean, it's usually not true because so much of the waste is added on by other players, pharmacy benefit managers and others who don't make drugs, wholesale drugs or retail drugs. So I am constantly on interviews saying, hey, quit talking about the lack of R&D that this is going to create because we're not going to let middle players add on 60% to the cost of insulin or whatever. But in this case, you have this, they're going to get 9 years to make some money on the drugs. But when you look at the types of drugs we're talking about, oftentimes they create a drug, they get this approval on a drug, and then they spend time doing trials for other related conditions or say cancers that have some related cause, and they'll find other ways that this drug can be applied or be useful or get good results for people. When you look at the way this price control program works, it could actually create disincentives for a drug manufacturer to find broader market use for the drug or find other diseases where it could help. Because if they get too successful with it, they might get into the price control list. So I could see where that could backfire, and that to me is a real risk. I think if they were to just put all this to the side and call me, not that they're going to, and say, hey, how could we lower the cost of prescription drugs? That's only because of lobbying has that ever been difficult. Don't let the middle players add 30, 40, 50, 60% to the cost of drugs. That would do way more than price controlled on 10 drugs.
No, right. I think they could do a bigger chunk, but of course they've got to keep those PBMs that donate heavily to both parties in business and keep their palms buttered too. Yeah. So what about insurance health benefits? We talked about this in the spring that some benefits for Obamacare subsidy recipients were going to go away. Where are we on that?
Well, they're also hoping to include that where they'll extend the subsidies. And that's usually how this game is played. We put something in, they'll get something in temporarily. Like with COVID relief, we took away nobody was going to pay more than 8.5% of income. If they went to the exchange to get a health plan, nobody had to pay more than 8.5% of income, which meant the 400% of federal poverty line rule went away, and you could have a couple and a 60-year-old couple making $215,000 a year that got a subsidy for their health insurance. And so it created a draw, moral hazard in our business, created a draw to take people like that from existing coverage that they had, whether it was through their employer or from the marketplace or whatever, individual plans. So we drew people onto government plans that I think you could make an argument for the fact that maybe they didn't need that assistance, and now they're looking to extend that. So they want to put a bunch of more money in there because it's going to run out by the end of the year, right around election season here. We would have the potential for millions of Americans that are getting subsidies today to no longer get those. Now, I see a lot of alarmist discussion about it in the media where they're saying, well, shoot, millions of people are going to lose their health insurance. Actually, most of those people had health insurance. We didn't. If you look at the numbers that moved over compared to the overall change in the uninsured, we moved the needle on uninsured like a point and a half, but we brought way more than that over to government rolls from other plans. And so that's the untold part of that story that I think we should at least include in the conversation.
Yeah, speaking of coverage across America, I've read recently that we're at the lowest. Well, I think the Democrats have been bragging about the fact we're at the lowest. We have more people with health insurance now, I guess, than all time. I mean, they were really celebrating some great number in terms of the number of lives insured. That's probably not the whole truth. I mean, what's the quality of insurance? What's the coverage? How much is it costing? But your thoughts on that?
Yeah, I think it's technically accurate, but it gets back to what we were talking about. How many of those people, what did we have to do to get that done? And was that the most efficient way to do it? We're paying north of $21,000 per person we cover when we ask the government to do it. Health insurance is expensive no matter how you go about it, but that's the highest ticket price we have is when the government adds someone on. Because then the consumer doesn't see the cost. They have nothing to complain about. and the insurer knows, or the vendor, whenever you have a product that's going to get sold and they know an insurer is going to pay for it, the costs go up in the system. And, you see that in your business. It's just like the vaccines, like the testing for COVID. They were paying $5 in Europe for a test at a drugstore that our system is paying $100 for, or $120 for. And it might be the same test, might even come out of a factory here, get shipped over there, just like drugs, So it creates a lot of extra cost unnecessarily. So what did we spend to get that done? To move the needle 1 point, was that a good ROI? And was that the best way to accomplish it? I don't think so.
No, I don't think we would ever hold up the government involvement in in our lives when it involves economic transactions as the most efficient prototype that someone would want to build upon. That's for real sure. Well, so yeah, I mean, it's going to be messy getting there. It's going to potentially set up long-term consequences, which are not good for future sick people. As I think mainly about the lack of the impediment against motivation for R&D on antibiotics, because we're seeing an increasing amount of resistance and a fewer number of new antibiotics in the pipeline. What manufacturers are doing now is, because of the expense, the regulatory hassle, they're taking it and modifying one hydrogen atom. Nothing else really changes, and they market it as some other drug, and it's not really making an impact on the spectrum of the drug, the efficacy, or others. And that's where I'm afraid this kind of a scenario could lead us across the spectrum. Don't you think?
Yes, we need a real free market forces where that entrepreneurial activity and that investment gets rewarded, and that's my greatest concern with the price controls. That the industry will do what it has to generate profit, and that's not an evil thing. We need to build incentives, or I think government's role done right would be to create a framework where the incentives gave all of us as consumers the things that we want. And there's certainly a model for it. I mean, if you look at, I was driving down the highway today and I saw a big billboard, and I gave my wife my phone and said, take a picture of that. A dental implant for $1,899, and those used to cost so much more than that. But it's largely not an insured procedure, so we're watching quality go up and costs go down.
Yeah,
it's this very vague and not very transparent insurance payment model that is really not working well for anyone. It's not working well for providers. Well, for insurers it works pretty well, but providers, consumers, I keep thinking that it can't get more ineffective or intentionally ineffective, whatever you want to say, and yet it does. Yeah,
they find a way to screw it up. Yeah, especially the left, whenever they get their hands on it. But both sides, it's almost become the third rail now. And once these programs get in, they're never gonna take them back. And that's why those Obamacare subsidies, they're there to stay and probably grow as they gradually move us to what Barack Obama said. Yeah, Barack Obama said it. It's an incremental, shift to single payer. That's what he wants: universal health care.
That's what the 10 drugs are. That's the great concern, really. If you take away all opportunity for the industry to profit from solving the problems, will they continue to do the same quality of work and put the same quality of effort into it? Of course not.
Right. Of course not. No, they can put their minds to other industries and that can generate profit. Well, Paul Seegert, we thank you again for unpacking this for us. Folks, Paul's a managing partner at PCS Advisors, and they're a benefits consulting firm, have a lot of offices across the nation. So PCSadvisors.com, the website. Thanks so much for being with me. Really appreciate the analysis. We'll see where this goes.
Sounds great. Thanks for having me. Bye-bye.
All right. There's Paul Seegert.